Okay, I think we'll go ahead and get started. Sounds like the mics are on. People are making their way into their seats. Dr. Lynch is not here today, so I'm Susan May, and I'm going to be moderating today's Yale Cancer Center Grand Rounds. And I'm pleased to introduce our first speaker today, Dr. Herta Chao. As you can see, she holds both a medical degree as well as a PhD degree, and her PhD is in the area of neurosciences. And so she's going to be talking about kind of marrying those two areas together, her clinical work as well as her interest in cognitive function. And I first met Herta because she was one of the investigators we funded through our cancer survivorship pilot grant monies for her work looking at what they used to call chemobrain, which is the effects of chemotherapy on cognition. So she's going to talk to us today about her work in this area in prostate cancer. Dr. Chao?
Thank you, Dr. May. So I wanted to talk about the effects of androgen deprivation in prostate cancer patients. I wanted to first start out with a case, and this is one of the patients that patients like him prompted me to investigate this issue of androgen deprivation, a potential impact of cognitive dysfunction. And he was a 63-year-old gentleman when I first met him, Caucasian male. He was diagnosed with a Gleason 8 prostate cancer that was metastatic to the bone about 2 years ago when I met him. He had a very remote history of coronary artery disease requiring bypass surgery about 12 years ago, but otherwise didn't have any comorbidities. He started androgen deprivation about 2 years ago with excellent response, and his performance status was excellent. He exercises vigorously like 3 times weekly, and he even continues to work full-time as a consultant for medical innovation. Believe it or not, we do have veterans that, at the VA that are highly functional. And, but he was expressing to me that he was very frustrated about decreased mental acuity after starting prostate cancer treatment. I want to go started looking into the background and see like what is reported. So just to briefly introduce, in 2013, about 238,000 men will be diagnosed with prostate cancer. A large proportion will undergo androgen deprivation therapy at some point in the course of their treatment. And actually, one of the reports even estimated about 2.9% of all male Medicare patients will be on androgen deprivation at some point. And that's, we're talking about a huge number of men. Androgen deprivation has proven efficacy in metastatic prostate cancer. However, it is also widely used in early stage disease, and one series even reported that more than 1/3 of patients with only localized prostate cancer were receiving androgen deprivation. While there's no consensus on the indications and duration of androgen deprivation in men with localized prostate cancer or biochemical recurrence, and we really feel that we need a better understanding of the risks and side effects of androgen deprivation to guide our treatment recommendations. There have been extensively studied side effects of androgen deprivation that include constitutional symptoms, cardiovascular symptoms, endocrine, and musculoskeletal side effects. However, the effects of androgen deprivation on cognitive function is not well understood. I want to briefly talk about cancer therapy on cognitive dysfunction. As healthcare provider in oncology, we will always encounter patients that sometimes complain of decreased mental acuity, memory difficulties, or other cognitive dysfunction. And studies in women undergoing adjuvant treatment for breast cancer and reporting cognitive dysfunction have popularized the term chemobrain. In one series, up to 75% of cancer patients experience some degree of cognitive impairment during and after treatment, and in up to 35%, the cognitive dysfunction remains for months of years. And this is one series by Janelson's investigators. How about men with prostate cancer? So men undergoing androgen deprivation may experience some cognitive dysfunction too. The problem is these individuals frequently score within normal limits in traditional neuropsychological tests. And the problem is that majority of these neuropsychological tests were actually developed to assess major brain dysfunction, like patients suffering from dementia or the individuals who have sustained traumatic brain injury. The traditional neuropsychological tests may not be sufficiently sensitive to detect cognitive dysfunction that is less severe but clinically relevant for the patients. And the problem also with this majority of neuropsychological tests is there's a training effect. So if you did the test once and you do it repeatedly, it's very, very hard to detect any decline in function because you already have the training effect. So we wanted to test two hypotheses. One is androgen deprivation for prostate cancer leads to clinically significant cognitive impairment that is not detected by traditional neuropsychological tests. And the second was that we hypothesized that brain imaging with functional MRI is a better way to characterize cognitive changes resulting from androgen deprivation. I want to go to the background a little bit about what is reported so far about androgen and brain function. And there's a whole series of studies that several have shown that low testosterone levels have been reported to be associated with low performance in cognitive tests. And testosterone may have a moderate positive effect on cognitive function in healthy older men with or without hypogonadism. And that has been reported by Kenny and Sherrier in two separate studies. Similar results were also described in patients who had Alzheimer's dementia or mild cognitive impairment by several investigators. Where are the androgen receptors in the brain? And this is a nice picture from by Janowski, and you basically see that there are several areas. There's parietal cortex. Androgen receptors have been identified. There have been prefrontal cortex has androgen receptors identified, hippocampus and amygdala. So these are the areas where androgen receptors have been studied. So far, in terms of the reported effects of androgen deprivation in prostate cancer patients, there was many studies, and basically, you will find studies that show there's no effect whatsoever on androgen deprivation on cognitive function. You will find some investigators reporting a global cognitive decline, and there will be other studies that will also show some improvement and some decline in certain areas of cognitive function. And the problem with all of these studies is there's a small sample size, there's differences in patient demographics, there's lack of consistencies on how androgen deprivation was accomplished. There's a lack of consistency in the psychological tests used. And the problem with many of these studies also is there's a lack of age-matched controls. And many of the studies also use tests that are subject to training effect. And what is functional MRI? Why did we set out to study this in androgen deprivation? It is a non-invasive technique that directly measures brain activity and visualizes how the brain operates while performing a cognitive task. And it is used by clinicians to study whether specific brain processes are affected in patients with medical conditions. It has been studied in patients with heart disease, in children with cerebral palsy, and it has been used very effectively to see how certain brain processes are changed in these individuals. And preliminary studies using PET and functional MRI in breast cancer patients have demonstrated changes as a result of chemotherapy and tamoxifen on brain function. Functional MRI is also a very sensitive technique to detect changes in brain activation. So for instance, in patients with schizophrenia or patients with drug abuse, you can actually see that they score completely normal on the neuropsychological test, but unfortunately, you can actually see that there are changes in the brain while they are trying to complete the cognitive tasks. This is one of the studies actually had established the role of a functional MRI to study brain activation. And this is actually one of the groundbreaking studies by local thesis published in Nature in 2001. And this is actually a very elaborate study that combined single agent recording, multiple neuron recording, and local field potential. At the same time, these investigators had actually also done functional imaging in the brain. And the monkeys were exposed to visual signal. And basically, these recordings were done in the visual cortex of the monkey's brain. And you can see that if you do single unit recording or multiple unit recording, there's really no sustained effect. But when you look at the local field potential, you will see there's activity. You can detect activity as long as the visual signal is there. And this is the bold signal, the blood oxygen level dependent signal of the MRI. And it correlates beautifully. So this is a shorter signal. You see that the local field potential is shorter, and the bold signal is the same duration, and same here. What happens? What is blood oxygen dependent signal? It actually is a change, a metabolic change, because neuronal activation increases oxygen consumption in the brain. And there's a change of oxygenated and deoxygenated hemoglobin. And because of oxygenated and deoxygenated hemoglobin having a different type of magnetic signal, you will see changes in MRI. And our aims of the study is first to study whether androgen deprivation influences neurocognitive performance. And the second question was, do prostate cancer patients undergoing androgen deprivation show changes in brain activation while performing a cognitive task in their functional MRI scanner, as compared to patients who do not receive androgen deprivation? And are changes in brain activations resulting from androgen deprivation associated with changes in quality of life? The study design was a prospective cohort study that used functional imaging combined with a cognitive task called a stop signal task to examine regional brain activations in prostate cancer patients undergoing androgen deprivation for 6 months. Only patients that had non-metastatic prostate cancer, we didn't want to have confounding effects, were allowed to go on the study. Patients were planned to start adjuvant treatment to radiotherapy or biochemical recurrence to start androgen deprivation were on the study arm. And patients who with history of prostate cancer who had never been treated with androgen deprivation were on the control arm. And the decision about whether or not androgen deprivation would be used in one patient or not was based on the current best treatment guidelines. The patients were all matched by age and level of education. They had to have very good performance status, ECOG 0 to 1, no active second malignancy, and no significant cardiovascular, hepatic, renal, or neurological comorbidities. Also, psychiatric disorder was not allowed. And I did allow nicotine dependence because otherwise it won't be impossible to enroll any veterans onto the study. The score on the mini mental test had to be 27 or above, and no contraindications for MRI study. At baseline, all the patients were assessed with physical exam. They had to fill out standardized quality of life questionnaire. I actually chose this because it was free. I didn't have to pay for it. It's actually very, very well studied already in different type of studies and well-published data. So I thought this might be straightforward to use the FACT-P standardized questionnaire. And we chose neurocognitive testing with MBAC memory test. I will elaborate more about it. And then the functional MRI at baseline and at 6 months with a stop signal test. The castration level of testosterone had to be documented at 6 months in the study arm. So we started to cognitive function was with inhibitory control with the sub-signal test. Basically, we all have a tendency to form habits, and the sub-signal test basically try to see how well you can actually inhibit a habit. The second cognitive function was working memory, and we set it out by testing it with a 2-back memory test. First explanation of the sub-signal test is the stop-signal test has two signals. One is the goal trials and the stop trials. Majority of them are goal trials. So when you see a circle like this, the individual has to just press a button and respond to it. And basically, whenever you see it, you respond to it, it forms a habit. However, after you have been formed the habit with this, you actually try to, there were 25% of the signals are stop signals, and you have to basically withhold the response, so you should not press a button. And you can actually measure how the response is with that. The second is the working memory test. With the NBAC, I don't think it's working with the laser, but I'm just going to talk. So with a 0-back, you just detect a target. If you see on the screen the different letters and you see the X, you respond and press on the button. Then you can make it more difficult. 2-back, you basically have to remember what the sequence of the targets were. So you have to remember 2 steps ahead of time, earlier, what signal it was. So if you're looking for A and 2 steps earlier was A, you have to respond when you see another A. So these are the results. We had, in this analysis, I actually just analyzed 30 patients, and 15 were treated with androgen deprivation, and 15 had no androgen deprivation. And as you can see, the age is actually very similar, maybe slightly younger in the control. Education is very well matched. The mean mental status at baseline is also all equivalent. In fact, it was higher than I had anticipated. Then in terms of local therapy, the patients with the androgen deprivation had all radiation therapy and androgen deprivation. And in the control, there were a few patients with radiation alone, surgery, majority of them, and some people had surgery and salvage radiation. The quality of life at baseline is actually similar in both groups. And at baseline is actually also similar, so not significant changes. Testosterone level was documented to be in castrate at 6 months in the androgen deprivation group, and to be in a normal range in the control arm. This is a very busy slide, and I just want you to focus on the p-value. Basically, whatever you do in an NBAC on a memory task, we could not see a difference of 6-month androgen deprivation. It's actually the same whether you look at the patients with androgen deprivation therapy versus the control group. Then the behavioral performance in the stop signal task was actually also the same. So none of the p-values were significant. So to summarize the results so far is androgen deprivation for 6 months does not affect the quality of life scores and does not affect the scores on NBAC working memory tasks and stop signal tasks. However, on the next slide, I'm going to show you that androgen deprivation for 6 months does decrease brain activation on functional MRI. And this is the results. So you can see on the left-hand side, you see the baseline, so control B and the ADT baseline. And you can see about the brain activations in different areas pretty much the same. And one of the areas we focus, which has been well studied, is the medial prefrontal cortex that has a significant role in inhibitory control. So we actually focused one of the analysis in there. The control at follow-up basically shows a similar type of brain activation pattern. But when you look at the follow-up in the androgen deprivation group, basically throughout the brain activation is decreased. The next question that we asked was, so if function MRI with a cognitive task changes the brain activation pattern, what about in the resting state? And I just want to explain a little bit. I didn't want to get into too much detail in the introduction. The reason is resting state has a very valuable role. You basically don't have to ask them to perform a task. Patients can just sit and close their eyes, not fall asleep, and you can measure brain activity because the brain is functioning even at rest, and you will always have spontaneous fluctuation in both signal. And resting state functional MRI is a powerful tool that has been used by a lot of psychologists, psychiatrists, neuroscientists to study the interactions between different brain regions. So we actually went out and do another analysis in these patients. We also performed after they recovered from the subsignal task, basically just resting functional imaging. And this was actually a bit of a nice surprise. We actually were able to show that androgen deprivation for 6 months disrupted the connectivity, the functional connectivity between different brain regions. So the way we analyzed it is basically using the medial prefrontal cortex as a seed area, and then from that area we did the connection between different areas of the prefrontal cortex of the insula and the anterior cingulate cortex to see whether or not how the connection is preserved. And we were actually able to show that it's disrupted after 6 months of androgen deprivation. So the limitations of the studies is pretty obvious. I mean, we're talking about a very small sample size. We're talking about limited duration of androgen deprivation, limited follow-up, obviously because the funding wasn't enough to do a long study over several years. And we cannot also answer whether changes in brain activation can worsen over time with or without continued androgen deprivation. And we also cannot answer whether the changes in brain activations will eventually lead to clinically apparent signs or symptoms. To sum up, using very sensitive techniques involving functional imaging, androgen deprivation therapy for 6 months suppressed brain activations during cognitive control and disrupted brain functional conductivity in prostate cancer patients. Functional MRI combined with the cognitive task in resting state functional MRI can be developed to systematically characterize cognitive side effects of cancer therapies. And what are the future directions? Obviously, the question is whether the effects are reversible. What are the impact of long-term androgen deprivation? I have to say, we also have to develop better questionnaires to document subjective assessment of cognitive function. I realized later that the FACT-P is a wonderful questionnaire to assess quality of life in terms of social interaction, whether side effects from physical side effects from androgen deprivation or chemotherapy for prostate cancer. But it doesn't include any questions for cognitive ability. So I chose the wrong questionnaire, and Dr. Ruth McCorkle will guide me in how to develop better questionnaires. The other question is also like, how can we define more refined criteria to identify individual patients at risk to see whether we can develop tools to counteract the effects and techniques for treating or preventing cognitive side effects from cancer treatment. Why bother with this study? So there are over 11 million cancer survivors in the United States alone. And the American Cancer Society actually cites on their official website for patients that there's an estimated 15 to 70% incidence of brain problems in patients who are undergoing cancer treatment. So we're talking about a very large number of patients. I want to thank the patients. I want to thank my mentor, Dr. John Concado, Dr. Ruth McGaughill, who's been very, very helpful in designing future questionnaires and future studies, Dr. Mikhail Rose, Dr. Ed Uccio, and Monica Delvey and George Hayner, all at the VA, who have helped tremendously with the study. In psychiatry, Dr. Ray Lee and his team, biostatistics, was by Dr. Liu, and he's now at Brown University. And it was funded by the Yale Cancer Center Connecticut Challenge Cancer Survivorship Grant, by the Yale Cancer Center Translational Pilot Grant, and an R3 from the NIH. Thank you.
It's a really interesting and provocative study. I've got two questions. First, there's been recent evidence, of course, in castrate-resistant disease that the prostate cancer itself makes its own androgens. Does the brain have a similar pathway that while patients are under androgen deprivation therapy, that they can make their own testosterone? And perhaps that's one of the reasons why you see variability in your cognitive studies.
Yes, that's an excellent question. I mean, I think it would be very, very important to see whether there are different type of androgen receptors, basically, or whether the brain is able to, the cells are able to make their own androgen environment. Yes.
And then as a follow-up to that, with the newer anti-androgens that are being developed, I've often seen a profound fatigue that these patients develop. Could this also, some of these newer treatments where you're actually preventing translocation of the androgen receptor and then maybe crossing of the blood-brain barrier, have there any plans to study this in terms of these potentials?
Let's do it together.
Great.
I have one question. So if you see changes in the prefrontal cortex in these patients, do you see any changes in behaviors like smoking in these VA patients once they go on androgen deprivation therapy?
That would be great if I have a treatment for everything, right? I actually didn't look into that, but I think that's definitely something that we should capture in prospective study in the future.
Okay, I think we'll move on to the next speaker. Stay on time.